Hello, my name is Darren Bernard Williams. This is my introductory to my literature review of Anorexia Nervosa. Beginning with the history, eating disorders are characterized as persistent disturbances of eating or eating-related behaviors that result in the altered consumption of food and the dysfunction, digestion, and absorption of food significantly impair the health or psychosocial functioning of the patient experiencing disordered eating. Of the disordered eating disorders listed in the DSM, anorexia nervosa is one of the most severe and most difficult to treat. One of the key features in diagnosing anorexia nervosa is self-starvation. Self-starvation has shown an evolution in both its methods, ideology, and motivation over time, reaching as far back as the Middle Ages, leading to the more common typical traits featured in contemporary Western culture. The notorious symptoms of the anorectic self-starvation appeared during the Middle Ages, conceptualized as a focus on spiritual purity, penance, and moral stiffness. As time progressed, self-starvation as a penitential practice began to decline, with the exhibition of starving as an extraordinary ability emerged in the 16th century, symbolizing perfectionism. On the cusp of the 18th century, self-starvation began to be viewed as an abnormal behavior described as nervous atrophy. The behavior was theorized to have a psychological etiology supposed to be the effect of an ill and morbid state of the spirits. By the end of the 19th century, the psychological etiology of anorexia nervosa was confirmed. The behavior of self-imposed food refusal or restriction with adjunct somatic symptoms was realized to be a dysfunctional glorification of emaciation and a drive to maintain perpetual thinness. In 1952, anorexia nervosa was characterized as a neurotic psychophysiological disorder and was categorized as the first eating disorder in the DSM. Some of the symptoms that are hallmark in anorexia nervosa are used to classify, evaluate, and diagnose a patient with the disease. Because of the nature of anorexia nervosa, there are certain physiological and psychological criteria required by the DSM in order to make a definite diagnosis to proceed with treatment. The most significant psychological feature of anorexia is extreme over-evaluation of shape and weight. Anorexics experience intrusive thoughts about body image that causes him or her to experience distorted views of weight and thinness. This persistent dread of becoming fat causes patients to have distorted and poor attitudes about food and body weight, deny feeling hungry, avoid meal times and situations involving food, experience anxiety about eating in public, and develop an intense fear of gaining weight. These dysfunctional psychological symptoms lead to the physiological symptoms experienced by anorectics. Anorexic patients severely restrict food intake to self-imposed extremes in order to achieve weight loss. Behaviors inimical to the anorectic self-image may begin to emerge, such as body checking. Body checking is the repeated weighing, measuring, and mirror gazing in order to make sure that they are still thin. It becomes an obsessive behavior. The patient experiences dramatic weight loss, dressing in layers to hide weight or remedy his or her inability to stay warm, refusing to eat certain foods, which may progress to restrictions up against entire food groups, and develop food rituals such as eating foods in certain orders, excessively chewing, or rearranging food on a plate, and withdrawing from friends and activities in exchange for more social isolation. The anorectic's neurotic cognizance causes feelings of ineffectiveness, inflexible thinking, and develops strong desires for control and experience overly restrained initiative and emotional expression. Because anorexia nervosa is a psychophysiological disorder, patients also experience many physical symptoms and side effects. These physical symptoms may vary depending on the subtype of anorexia. Patients experience gastrointestinal pain, menstrual irregularity, constantly feeling cold, difficulty sleeping, dry and brittle skin and nails, thinning of hair, muscle weakness, impaired immune functioning, anemia, low thyroid and hormone levels, low potassium, low blood cell count, slow heart rate, and a fine body hair that develops all over their body called lanugo. The aforementioned symptoms are experienced by the restrictive subtype of anorexics who diagnose based on their restrictive behaviors. Anorexics diagnosed with anorexia binge eating/purging type experience the aforementioned symptoms along with complications due to the patient's engagement in compensatory methods of for eating through binging and purging. Anorexics diagnosed with binge eating purge subtype may binge eat food due to hunger from extreme starvation, purge the food to compensate for eating and or lose more weight. Purging practices include self-induced vomiting, laxative and diuretic abuse, and overexercising. Because of this, the subtype of anorectics may have cuts and calluses across the tops of their fingers as a result of self-induced vomiting, cavities, tooth sensitivity, and enamel erosion as a result of their teeth's exposure to stomach acid, and swelling around the area of the salivary glands. The etiology of anorexia nervosa and the causation, like many mental disorders, is not completely understood, but has many biological, psychological, and sociocultural interpretations. Biological factors include both genetic and neurobiological effects. Studies of twins from both monozygotic and dizygotic, or identical and fraternal twins, indicate a link between anorexia nervosa and heritability. Although data did not show fraternal twins both meeting the diagnostic criteria for anorexia nervosa, 29 to 50% of identical twins did show concordance with anorexia nervosa. Neurobiological studies show that altered serotonin activity affect individuals with anorexia before, during, and after recovery. Serotonin is linked to both mood and appetite regulation. Alterations in the reception, activity, and transport of serotonin is believed to affect symptoms that are common in anorexia nervosa, such as persistent anxiety, perfectionism, obsessive behavior, problems with response and inhibition, heightened vigilance, and suicidality. Psychological factors that may cause anorexia nervosa are body image disturbances. Body cachexia is the degree of body dissatisfaction and satisfaction that is believed to be an integral part of self-esteem. Individuals assess their bodies by measuring them against the body type of the culture that is ideal. The result of this is self-assessment determines body satisfaction or dissatisfaction. Individuals who reported higher body dissatisfaction were at risk of developing eating disorders. Certain personality traits place individuals at a higher risk of developing anorexia nervosa. Personality traits common amongst anorectics are impulsivity, novelty-seeking, stress reactivity, harm avoidance, perfectionism, interpersonal distrust, interceptive awareness, and a fear of maturity. Western culture has valued thinness as the ideal type of body for some time. This glorification of thinness has a sociocultural effect on individuals with anorexia nervosa worldwide, not just in America. Over the past few decades, the ideal body image has become thinner and thinner. The growing fitness industry has falsely equated health with thinness. Not only are individuals bombarded with social pressures and media images that deify thinness, the dieting industry has had a stark effect on the prevalence of eating disorder as well. The Western world highly advertises cheap, calorific, and highly palatable foods, which is in stark contrast with the excessive value placed on thinness. All this together goes into hurt and cause anorexia nervosa. The diagnostic criteria for anorexia nervosa is the refusal to maintain body weight at or above minimally normal weight of one's age and height. The patient's weight loss leads to a maintenance of body weight less than 85% of that expected, or failure to make expected weight gain during a period of growth. Anorectics also display an intense fear of gaining weight or becoming fat even though he or she is underweight. The weight loss is self-induced by avoiding fattening foods, self-induced vomiting, excessive exercise, the use of appetite suppressants, and or diuretics. The patient experiences a disturbance in which one's body weight or shape is experienced, undue influence or shape on self-evaluation, or denial of the seriousness of his or her low body weight. The patient has a distorted body image. This forms a psychopathology which the dread of weight gain persists as an intrusive, overvalued idea that causes the patient to impose a low threshold on him or herself. The patients experience an endocrine disorder involving the hypothalamic pituitary gonadal axis, causing postmenarcheal females to experience amenorrhea, the absence of at least 3 consecutive menstrual cycles, and a loss of sexual interest and potency amongst men. Due to anorexia nervosa's effect on the endocrine system, elevated growth hormones, raised cortisol levels, changes in the metabolism of the thyroid hormone, and abnormalities in insulin secretion may also be present. Anorexia nervosa is a terrible disease that affects one both physically and mentally. And it has a very, very, very complex treatment plan. This treatment plan will be covered along with the Christian worldview in my presentation that continues. I hope you enjoyed this, and I hope you learned as much as I did. Thank you.